Hello, Cynthia Allen, and we are back for Move Better, Feel Better, the Feldenkrais Awareness Summit. And we're in this theme of original breath. And we have with us here today Dr. William Hang. He is going to present to us an interesting topic. He's named it Recessed Faces plus Poor Breathing equals Poor Body Posture. Wow, okay, that's going to be interesting for all of us and in Feldenkrais land for sure. So Dr. William Hang has been a pioneer working in the airway sleep and air arena for over 25 years. He received a Lifetime Achievement Award from the American Academy of Physiological Medicine and Dentistry for his work on optimizing airways in all patients. Patients travel from at least 28 states and a number of foreign countries seeking reversal of their previous orthodontics, elimination of their TMJ pain, and relief from breathing pattern sleep disorders. He is an innovator, forward-thinking visionary. He's dedicated his career to improving how dentistry and orthodontics are practiced around the world. Welcome, Bill.
Thank you. I'm happy to be here. Happy to have the opportunity.
Oh, I'm really pleased because this has been such an interesting topic for me over the last few years. I've been in an interdisciplinary group with a variety of people discussing airways, and as you know, Dr. Nelson Deers is part of that group, and it's just really been fascinating to hear about this from some other perspectives and kind of open my eyes and my thoughts to some things I hadn't thought about. And then, of course, this year we had the gift of James Nestor releasing his book, which really, I think, opens the pathway for even deeper, richer discussions.
Absolutely. It's a great book.
Yeah, and so thank you for, having been in the field for all this time, kind of slogging and doing the hard work of moving against the tide for an entire profession. God love you.
Yeah. It's been a journey and I've enjoyed it.
Good, good. Well, I'd like to just find out just a little bit of what made you get so interested in this topic.
Well, I was a traditionally trained orthodontist like everybody. I came out of school, learned how to do what I was taught to do, and that's what I did. I did it for 5, 6 years, 7 years maybe, before I really began to look critically at the faces that I was treating, and I didn't like what I saw. The faces looked worse after treatment, and at that time there was a lot of talk about orthodontics causing temporomandibular joint problems, and that was coming from the general dental community. And I was the orthodontist, and I was kind of put off by that. But I opened my mind to it after seeing the faces and actually listening to my patients and seeing what was going on. So after about 6, 7 years of practice, I looked critically at it and decided I couldn't continue to do what I was doing. The faces didn't look good, and I had to do something different. Either that or get out of the profession. So it started in 1981, a continuing education process that has taken me all over the United States. I've been to 50 states and more than 30 foreign countries, and I it's all consuming. And once you have some doubts about what you were taught in school, then you doubt other things, and pretty soon you're doubting everything, and then you're on a quest to find answers, which is kind of what I've been doing all these years. And to me, what I do makes total common sense. If it didn't, I wouldn't be doing it. And I've been at it for, well, I've been in orthodontics for 48 and a half years. The first 7 years I'd like to pretty much forget, but from then on, when I started to change, it's been really gratifying. And I get a lot of favorable feedback from my patients, which is what keeps me going.
Bill, you're really talking about a crisis of faith or a crisis of science because you were going off of what you had known to be true and were educated in. Not everybody makes a shift like that and has to be quite challenging, but it seems like for you it was almost like no choice.
It, I hate to be simplistic, but one of the proudest things I am in my whole life is I'm an Eagle Scout. And you want to help little old ladies across the street when you're an Eagle Scout, and it doesn't change. That's the way I was raised. And my dad taught electrical and nuclear engineering at the University of Illinois, and he was a very, very skeptical person. He raised me that way. But I learned in school, I didn't ask the questions of why, I just asked the question how, as most orthodontic residents did. It just took me a long time afterwards to gain the confidence and say, wait a minute, this isn't making sense. And after you have a few years experience on your own, you can make your own choices and say, wait a minute, this person doesn't look as good. And when they come to you and they say, gee, I can't breathe as well, and the only variable in their life has been that you took out some teeth and you pulled the teeth back in their face. Well, you can't say it's a direct correlation, but if you hear it enough times, you're silly if you don't begin listening. And one of the things I'm proudest of is I really say I've learned more from my patients over the years than I ever learned in school. And that's the critical thing, is to know how to listen to the patient and know what they're saying, and determine what they're saying, what does that really mean? And then more than that, how can you best address the issues that they present with? So that's
Wow.
what's
Okay.
happened for me, and that's why people fortunately trust me, and I get contacts almost every day, an email from somewhere in the world with someone who's had teeth taken out. They don't like the way their face looks. They don't like the fact that they can't breathe, and they have a pain pattern, and everything about their life has changed. And to be honest with you, a number of them are suicidal, which is very sad. That doesn't mean that everyone who's had retraction is this way, but I'm here to say that I think a very significant number have had issues that they don't understand are related to this kind of retraction.
Okay, and just for those of us who might be completely ignorant, retraction means the removal of some teeth.
Well, in general, that's the easiest and usual way, but anything which pulls the teeth back in the face, it can consist of using a headgear, which goes around the back of the neck, and a piece of metal to retard forward growth of the upper jaw. And that's been around for about 100 years or more. It's still being taught, even given the fact that literally in 1981, an article appeared in our refereed literature saying in those patients where we assume their teeth would stick out, we call that a class 2 malocclusion. Person on the street would say, Bucky Beaver, whoever has buck teeth, you assume that the teeth are too far forward in the face. But as of July 1981, in our refereed literature, it's been noted that those teeth really don't stick out. As a matter of fact, if they're not in the right place, they're usually too far back rather than too far forward. And here we are nearly 40 years later, still retarding the growth of the upper jaw. And either via headgear, by use of elastics, or with removal of teeth and then bringing the teeth back. It's much of what is done is retractive in nature. When you consider that the tongue is sitting there and has 4 cranial nerves innervating it, and I guess we're told as orthodontists, well, the tongue will adapt. Well, I have no reason to believe that the tongue does adapt and get smaller. There's no evidence in the literature to support that. And for so many people, it becomes a big issue for them.
Mm. Well, I know you have a presentation for us. I think maybe I'm going to let you go to the presentation,
Okay.
and when you come back, I'm going to maybe grill you just a little bit on whether we should all have buck teeth or what we should be looking for. So,
That'll be fine. I'd look forward to those questions. So,
good.
well, thanks again for the opportunity to present to you some thoughts I have. The title here is Recessed Faces and Poor Breathing Equals Poor Body Posture. We might have another title for that, even add on more to it, that indeed in many cases it involves pain in the jaw joints, sleep apnea, and it can be related to all chronic diseases, including heart attack, stroke, diabetes, Alzheimer's, you name it, is related. All those chronic diseases are related to poor breathing and sleep apnea. But let me give you a little bit of a disclaimer here of who I am and where I came from. As I noted earlier, I'm a traditionally trained orthodontist and was pretty much doing what I was taught to do until about 1981. Long story why I changed, but I looked at the facial balance and whether or not TMJ problems were a big issue, and I didn't like what I saw. So I knew I had to change or get out of the profession. So over the years, my practice has evolved slowly to where I now don't retract in any way. The big thing that I look for is to create the best facial balance, optimize the airway, and get the jaw joints happy and healthy. I began reopening previous orthodontic extraction spaces where people had bicuspid teeth taken out and reversing this problem in 1989. And I've done it for hundreds of people from around the world since that time, including myself, actually. So we've had a lot of patients that seem to find value in what we do, and we're happy for that. I wish I could help more of them, and I'm trying to train people around the world to do what I do. And so, as I said earlier, I've learned more from these, politely call them train wreck patients, than from school. These are the folks who've had pain patterns that have gone for 10, 20, 30 years and spent sometimes several $100,000 and have not found resolution. So why don't we just start out and actually listen to one of those people? And this is a woman, a Japanese American woman who weighs about 80 pounds and had horrible sleep apnea, she thinks, because she had bicuspid teeth taken out. And here she is, 4 days post-surgery, and you can read what she's saying here. And she went on a walk that morning, 4 days post-surgery, and then took the little rocks from the rock garden and put them out on the sidewalk and spelled out, "I breathe." And she said these kind words to me. Furthermore, here she is, and you can see her airway between the red arrows. That airway is bigger than mine and probably anyone listening. That's a monstrous airway she has now. But here she says, "I can't begin to tell you how much better I feel. It feels so unbelievably good to breathe. My diaphragm moves. I don't have to suck in the air, and I feel so calm. I'll never, ever, ever be able to thank you all enough." This is a woman where we've reversed the retraction by reopening extraction spaces, but in her case, it actually took moving her jaws forward surgically to get her where she needed to be. Let's talk about why people have poor facial growth and reduced airways, and how their head posture and their body posture changes. The smartest orthodontist in planet Earth is John Mew from London, England. He's now 92 years of age. I first heard him speak in 1990, and it changed my life. He says that altered oral posture, usually secondary to airway issues, causes facial growth to fall short of genetic potential for ideal growth. It also has to do with what we eat and what we don't eat. What you need to do is you need to eat very coarse foods, and we need to stay away from the typical Western diet. There's a lot of evidence to support all of this, but I can't go into it in just a short time here. So what is the definition of proper rest oral posture? We want to have the teeth lightly together, the tongue firmly to the palate with the lips together without strain, and the facial growth will go according to that person's genetic plan, and the face will go forward more so than down and back. And the overall body posture will be better as well. And we'll show that in just a minute why that's the case. This then is a slide from John Mew depicting the changes that we typically see in all industrialized societies. So if you look at age 3, 7, and age 50, you see that the face changes. The dotted line is where the face ought to be, but the black line is where it ends up being as our faces fall back due to poor rest oral posture, mainly mouth breathing, but much more than that, not having the tongue to the palate. And there's great evidence to support this in the literature. I got plenty of references, but we can't put them in a short lecture.
When you say that that's where the face should be, what is that based on?
Based on what we think our ancestors looked like, and our ancestors' faces were massively forward from where ours are now. There's a book by Daniel Lieberman, an anthropologist at Harvard. He's documented all this kind of thing very, very well. For those who are interested, they should read it. He's a PhD anthropologist, and he's talked about how our faces are substantially back. Now, all you have to understand here is because the upper jaw is back, the soft palate is back. Because the lower jaw is back, the tongue is back, and what you're getting is a train wreck at the back of the throat and the pharyngeal area where the airway is reduced. What's so simple to see, and you can see the change in posture here. You got the red line on the little child at age 3 is a vertical forehead, and we're supposed to have our foreheads vertical. But as you see, the forehead will tip back more and more and more. And that's nothing more than a compensation to keep the chin forward, to keep the airway open, to get the lower jaw forward. In addition to that, you'll have forward head posture. Sometimes you'll see people that get their head forward 2 or 3 inches from where it ought to be. And believe me, that has a cascading effect down the entire spine, and the rest of the body compensates. So we see people that look like the one on the age 50 all the time. You see the bump in the nose, which is really the nasal bone in the proper position, but the cartilage part of the nose falls down and back as the entire lower jaw falls back. Patients like this are less attractive, and indeed their airways are often compromised. So let's then talk about, can orthodontic retraction cause the growth of the lower face to change? I have plenty of detractors in the profession who would say that, you know, I'm kind of crazy, maybe very crazy, and that this can't happen. Well, my response is, let's look at the refereed literature that's out there and let's see. Okay, so here we have a not uncommon thing where a child is congenitally missing the upper lateral incisor teeth. And this is an article from the late 1980s out of the American Journal of Orthodontics and Dentofacial Orthopedics. So this boy is missing lateral incisor teeth, just like Michael Jordan is missing the upper right one. Larry Bird, the basketball player, is missing both of them. And Oliver North is missing both of them. It's not uncommon. So between age 8 and 12, he has expansion of the upper jaw, which is very routine and very good. It's a good thing because we have low rest tongue posture. Many of us have narrow upper jaws. So expanding the upper jaw is great. So see, what happens here is the upper teeth come down and forward as they normally would, and that's what orthodontists are taught will happen. The most important thing to note here is that the lower jaw comes forward massively in this 4-year time frame, as we're taught it should. This is what we call normal growth. Now, I look at this article in a much different way. Now we see what is done. They have taken the eye teeth, which are next to the lateral incisors, and collapsed them together to close the space to where these teeth were missing, instead of putting in an implant. Now, what has that done? You see what's happened to the upper incisor. It was forward, and now in the dotted line, it's been retracted back, as you would expect. Now, the important thing to look at here is the fact that no longer is the lower jaw growing forward, even minutely. Not even minutely. And I think this happens very, very, very frequently. Now think about the impact of that. Reduced forward growth of the lower jaw means the tongue is going to stay back, the airway is going to be compromised. And in reality, I think what we see is the face height will lengthen frequently. Here then is an example of a man in his mid-50s who has had this exact same thing done. You see this, where the arrows go, that's where his missing laterals should be. And the teeth adjacent to that are his eye teeth, which have been over contoured to look like lateral incisors, even though they don't. Now, this man has sleep apnea, and he had a stroke, and he is no longer able to work. And the black line you see where his face should be is what we call the Bolton norm. I'll explain that. It was a norm devised in Cleveland, Ohio, back during the 30s and 40s. They took very attractive children and took head x-rays of them every year from age 8 to 18. And we use this as a way to compare where the face might be. Now look at the 33-degree forehead tilt. What you can't see here is that he has forward head posture. It's all a compensation for him to stay alive and breathe. So my point in showing you that little boy is he may well end up where this guy is. We have what we call airway-centric treatment. You can look at this child on the left, the x-ray, and then on the right. You can see how far back both jaws are on the left, and you can see how small the airway is. A 13.1 square millimeter airway is pitiful. It's horribly small. Doesn't really, very high chance of sleep apnea. On the right, you see how well the airway is now 186.1, which places this person in a very low risk for having sleep apnea. You can also look at the profile, and the face looks better on the right. This is the diametric opposite of retractive orthodontics, and it is I used a technique on this patient to develop the entire face forward that I learned from John Mew in London, England, starting 31 years ago, actually. The point then is, which airway would you rather have? Would you rather be breathing through the cocktail straw on the left or the garden hose on the right? So from my perspective, as the years have gone by, I can easily make this statement because I listen to my patients. So let's look at common patients that we see in a dental practice. Here's a guy in his mid 50s who has basically destroyed his teeth. And when I see somebody like this, the very first thing I think is he's going to have sleep apnea. Most dentists will look at this and say, wow, he needs veneers on his teeth. He's worn them out, without asking what the problem is. If we look at his face, and he hasn't had retractive orthodontics, his face is just back substantially from where it ought to be. And when he goes to get a sleep test done, this is the sleep test he had done. And the salient points are, is he stops breathing for an extended period of time, 454 times at night. And there's what is known as the apnea-hypopnea index of 72, which is extremely severe sleep apnea. Worse than that, he stopped breathing. His longest time stopped breathing was 64 seconds, and his arterial oxygen desaturation went as low as 70%. The point here is he's an accident looking for a place to happen because of his jaws being back and this problem with sleep apnea. Now, here's an innocent looking woman who unfortunately is not going to be home for dinner tonight, not because of her fault, but because she was in the Hoboken, New Jersey train station when this train came in and crashed into the station and killed her. So this is the man who was driving that train. And so when I look at him, I look at his face and look at his upper teeth, his jaw, it looks like his head got caught in an elevator door. It's incredibly narrow, very unesthetic, and his teeth are set back in his face. Now, I don't know this for sure, but I can virtually guarantee you he was someone who had 4 teeth taken out and was retracted. And I said to myself, this man has sleep apnea. And so his lawyer in this case, 4.5 years ago, confirms that I was correct. He had an undiagnosed sleep disorder. He went to sleep and the train crashed and the woman died. This kind of thing happens all the time. There are airline pilots who have sleep apnea and they don't want to get a sleep test because they know they'll get grounded. And truck drivers all over the place have sleep apnea. Here then's my life as a little boy who comes to me for a second opinion. Another orthodontist has said we need to remove these teeth because that's the way he was taught. Now, I've taken out teeth in this kind of case too, but not for the last 40 years or so. So we say, no, we're not going to take out teeth. Yes, we'll straighten your teeth, but the little boy has his mouth hanging open all the time. He has poor rest oral posture. Here we make his teeth straight. You can see that. Pat myself on the back. That's nice, but it's not really that great because his poor rest oral posture continues. And his face, if you look at what I'm showing there, doesn't look any different than what your kids look like, your grandkids or whatever. He's not an outlier. He looks like zillions of us in our society. If we look more critically at him, and here he is laying on the couch with his mother using her cell phone, he's snoring like crazy. Snoring, snoring, snoring. Now, snoring alone is correlated with plaque formation in the carotid arteries, even if you don't have sleep apnea, and yet he does. He's a kid, he hasn't even shaven yet, and he's in his mid-teens. That is his head x-ray, and that is his airway. And it is small, and he was diagnosed with sleep apnea. And I didn't take any teeth out in treating him. I did not retract him. And yet, because he had poor rest oral posture, his whole face continued to descend downward and backward. And this is what's going on for him. Now, what does that really mean health-wise? Ron Harper, a PhD neurobiologist at UCLA, says 5 hours of intermittent hypoxia can cause brain damage, killing Purkinje cells, which are responsible for motor coordination. And he talks about brain injury from sleep apnea increasing the chance of hypertension. He has MRIs of kids who've had this happen, and he can show you the brain cells that die. A very compelling lecture. The point here is it really isn't about the teeth. It's about our kids, their health. There's another book out there by an African American in Savannah, Georgia, a really great friend of mine, Why African American Kids Can't Read. Has nothing to do with the color of their skin, but many, by the time they get into first grade, have had so much problem with sleep apnea that they've had brain damage. It can happen to white kids, any color, doesn't matter the skin. It's just the way it is. Phil Cooper is the man who wrote the book, a very nice man, and he's trying hard to help kids have better airways. So here's what you do supposedly for the sleep apnea. You put what is known as a continuous positive airway pressure CPAP machine, and you think, okay, you put that on and you'll live a normal life. Well, that's all well and good, but out of the New England Journal of Medicine in August of 2016 was a study from Flinders University saying they were surprised to not find a reduction in cardiovascular events from CPAP usage. So it may make you feel better in the morning, but the very reason that people are wearing these things, it doesn't really help from a statistical basis. So we got to do better for our kids than this. Let's look at some facts and figures from some of the stars. Harvard-trained physician John Remmers says that the apnea will become the most common chronic disease in all industrialized countries. Here's a compelling statistic. 65 to 80% of stroke patients have apnea. 17% of the US population suffers. That's probably an old statistic. I gotta believe it's well over 20. And sadly, most of us don't know that we have it. It's undiagnosed. Here's an ENT from Arkansas, very well-known guy. 60 to 80% of snorers test positive for sleep apnea, and untreated sleep apnea is good for a 20% reduction in life expectancy. And as I said earlier, everyone who snores will develop sleep apnea if they live long enough. This is from James O'Brien. And back to Remmers, it's due to a structural narrowing of the pharynx in most cases. And this is the critical thing right now. He says it would not exist if both of the jaws were placed properly forward in the face. That's the big deal. It's not about NFL linemen who weigh 300 pounds. Of course, they all have that. But I have tiny Asian women who weigh 80 pounds who have it because they've been pulled back, as the one I showed you. So let's look at what the literature is saying about orthodontics and the airway, and a meeting that occurred literally 2 years ago this weekend, and I attended it. We'll get to that in a moment. But before we do, let's look at the referee literature. Here's one out of the Angle Orthodontist, a very well-known journal from China, talking about how the extraction of teeth does affect the airway and decreasing it. Another article, also out of China, large incisor retraction leads to narrowing of the upper airway in adult bimacular protrusion patients. Now one out of Turkey, showing that extraction does reduce the airway. Now from Stanford University, the best known name in all of sleep, Christian Guilleminault, with over 400 articles in the referee literature, talks about how the missing teeth and can cause less space and cause sleep apnea. And this is his conclusion, that later on at a later age, they may end up with sleep apnea. Finally, a fifth article from England talking about class 2 division 1 malocclusion, which the lay people would call that's buck teeth. And as a matter of fact, both jaws are too far back. So the last thing you want to do is to retract. 5 articles out of the refereed literature suggesting that retraction is not okay if you're looking at the airway. 2 years ago, and I was at this meeting in Marco Island, Florida, which was called a consensus conference, which is an interesting word since I've never seen the word consensus used in dentistry in my entire career. Since I got into dentistry in 1966, there's no consensus on one issue, even on fluoride. And this was a sign that was on before the meeting began, protecting the future of your specialty. I'll let you decide what that means. So let's listen to Christian Guilleminault, who was a speaker, but they had a white paper that was written before the conference even began. They had the final draft of it. And here is Dr. Guilleminault, who passed away 1.5 years ago. He says, orthodontists are still using headgear which can kill a 12-year-old boy. That's a direct quote. Any child who's a mouth breather during sleep is going to have drastic consequences to facial growth. And he says you must stop taking teeth out and you must treat the problem as soon as recognized. That would mean at any time after birth, And yet our organization says, well, come and see the orthodontist at age 7. By then, for too many people, the smoke is not just smoke anymore. By the time you get to age 7, the flames are going through the roof and you really need to treat. By then, many kids may have brain damage. Here's another speaker at that meeting who did his research and concludes that extraction of teeth does not affect the airway. Yet another one, the same thing, bicuspid extraction is not related. And here's his article out of the American Journal of Orthodontics. Orthodontic treatment in adults does not cause clinically significant changes to the volume or the minimally constricted area of the upper airway. Well, you can believe that if you wish. Here then is what I call the biggest issue around, the ones we need to really discuss. Here's a woman, my patient, who came to me. She's had teeth taken out. And you can see the bicuspid teeth are gone, her arches are collapsed. She doesn't have much energy. She sleeps about 2 hours a night, tosses and turns. She really needed jaw surgery, but before we did that, we opened these spaces up for her. You can see the full bicuspid width was opened up on the left-hand side. And by that time, she was really done. She was happy because that alone allowed her to breathe and sleep better. Just doing that. I didn't do surgery for her. She then went and got a sleep report from her sleep physician, and this is what he had to say. Her sleep apnea has completely resolved with orthodontic therapy, despite the fact that she gained 10 pounds. Quite remarkable how much improvement she's had in her apnea severity, despite the presence of a large tongue and crowded oropharynx. Her tongue isn't large at all. It's a totally normal size. Her face is back, and the garage that her tongue lives in is dramatically too small. Very few people have macroglossia, true macroglossia. Apparent macroglossia is very common because the garage that the tongue lives in has been made smaller. The point here is all we did in this woman, she gained 10 pounds, which would be a negative, making her sleep probably worse. Despite the fact that she's carrying 10 more pounds, her sleep problem has been completely resolved. Which then leads me to ask this question to groups that I lecture to, and I've been doing this for several years. And I would ask them, do you believe that you could retract enough to produce sleep apnea? And I asked them, is there even one person in the room who believes you could not retract enough to produce sleep apnea? And I've never had someone say, yes, I don't think it's possible. Everyone has agreed with me, every last person. Then my next question is, how far can you safely retract? And no one knows. And frankly, I don't either. I've been reopening spaces for people for 31 years, and I haven't figured that out. I don't think there is a way to know. Then the next question, which really gets dicey here, is, and I like this one, if you don't know where safe retraction becomes unsafe, how can you ethically and morally retract even minutely? I think that's a question that we need to answer in our profession. So what can we do? Now let's get away from all the negative stuff. Let's talk about how can we help people? Well, here's a family that came from Silicon. That's not actually them, but their daughter, here's their daughter, and they drove 400 miles from the San Francisco Silicon Valley area, probably 15 to 20 times for me to treat this young girl. You can look at her. She's had a soft tissue cleft repaired. As a very young child, she was diagnosed with sleep apnea. Now, the crowding that you see on her upper jaw is as much as you'll ever see on any human being. It relates to incredibly low rest tongue posture. So her teeth look like they've just been thrown in there randomly. And almost every orthodontist would look at that and say, there is no way you can treat her without removing teeth. If you try to remove teeth, if you don't remove teeth, you're going to push her teeth off of the bone support. You will cause recession and she will lose teeth. And that's what we're taught. That actually ignores 7 articles in the refereed literature that says that won't occur. She snores and sleeps with her mouth open, and she has difficulty eating. You think so? Showing her face, you can see how far her face is already too far back. That's where she should be. You can see that her chin is very recessed. You can see that her forehead is sloped back substantially. As we said earlier, it should be vertical. Hardly any of us have a vertical forehead, but it should be. And you can see her forward head posture. Her airway is in a high risk for sleep apnea right now. Right there, that's her airway. Where that little red line is, that's 65.2 square millimeters. She's pretty much in the range for a child to have sleep apnea. So here we are, believe it or not, we have a way, we lined up all these teeth over a matter of a couple of years, and you can see her with braces on, and you can see how much bigger that is. And here she is with the braces removed, and her teeth don't fit perfectly. The only way to make them fit perfectly would be surgery, because it's impossible to make her jaws grow forward at that age. But the family knew this going in. They're happy, she's happy. And please notice there's no recession of gum tissue. It's completely normal gum tissue. She's had no recession whatsoever. And you can look at this the maxilla on the left, and here it is on the right. And you can think how much better it is for her to be able to get her tongue to the palate, to have proper rest oral posture. And how might that then affect everything else descending from the head all the way down for the rest of the body, the lower back, the upper back, and all. She doesn't have to have the compensations that she would have had, particularly if she'd had teeth taken out.
Dr. Hen, can you tell us for a moment what you mean by rest oral posture? Because you've used the term several times. I'm not sure many of us know.
The proper rest oral posture means having your teeth together lightly, your tongue to the roof of the mouth, with the tip behind the front teeth and the back right up against the palate and against the soft palate, and the lips together without strain. It means nasal breathing, as James Nestor in his wonderful book talks about. And I'm going to get to those books. There's some other books to read later on. But proper rest oral posture is what we want to have. And if you have that, many things go better in your life. Nasal breathing is the only way to go. The next patient, I'm going to break all the rules also on and show you how to treat him. Here he is, and he has a slight, quote, bucktooth arrangement. And what is routinely done in cases like this is to use a headgear or remove the upper bicuspid teeth to pull the front teeth back. The front teeth that actually don't protrude, but we think they do. We've known that since 1981. We continue to retract anyway. Now I'm going to do something that is completely not the standard of care. And this is why I'm going to do it. Number one, because of his facial balance. But number two, you can look at his airway. Now, this kid is a huge kid. He played football in his teenage years on a football team here that sends people off to Division I schools all the time. And think about a football player trying to get air through that small airway. It's not much bigger than a drinking straw. So we do something that is completely crazy, which means advancing the lower 8 front teeth. We have a removable appliance in here, and we're literally pushing these teeth forward because to make the lower teeth come forward and meet the upper teeth. We're not going to retract the upper teeth. Now you see huge spaces have been developed, and we're now going to bring the back teeth forward into those spaces. You can see where the lower areas are here. There's a little screw in the bone with a little blue plastic chain that is hooked back to the molars in the back. And over a period of a year or more, we'll slide all of those teeth forward. You can see his panoramic x-ray where he has these spaces. He's not missing any teeth here. I literally created these spaces using the removable appliance, which pushed the teeth forward. You can also see that his 12-year molars are impacted in the ramus of the mandible because the reciprocal of that action pushed them back that far. Over the period of the next year, I brought them all forward, and you can see where the 12-year molars are perfectly positioned here. The entire lower arch has been moved forward in this case, the entire distance. So we literally slid the whole lower jaw forward. We could, of course, done surgery to bring his lower jaw forward, but I didn't want to do that. Not with a face like his, he didn't need that. This is not the standard of care. This is something that I decided to do and have done on a number of people because it made sense to me. I've not been taught this in school. And please notice there's no gingival recession. Look at his face pre-treatment and then after the treatment. What really would be fun to do is have him have an identical twin and then take the teeth out on the upper, retract him back, and then compare what does that person look like with this one here. I can tell you, I would always want to do what we've done here. And here he is when he's 20th with his grandmother and his sister on Facebook. And let's look at his airway, which was minimal cross-section, 60.2 millimeters on the left-hand side, up to 150.4 millimeters, square millimeters on the right. If you understand Poiseuille's law, which governs the flow of a gas in a tube, there's a lot of numbers in that, but the bottom line is the resistance to the flow of a gas in a tube varies inversely according to the 4th power of the radius of the tube. So when you see a change like this in the airway, you begin to understand just how important that is for his ability to breathe. For dentists and orthodontists who worry about pushing the teeth off of the bone support, please look at the image on the right. And then after I've done pushing the lower teeth forward, there is massive bone on the labial aspect of the lower teeth. He's not going to lose his teeth because I pushed them forward, and I pushed them forward a full bicuspid width, which is massive advancement. Now, let's go and see what we can do for an adult patient who is suffering, wearing an appliance, a so-called appliance. Here she is. She's in her mid-40s. She snores, and a home sleep test reveals mild to moderate sleep apnea. She wears a mandibular advancement device, which is a lower appliance which postures her jaw forward to open her airway. She still has a serious pain pattern because of her deep bite, and her lower jaw is trapped. When you see someone with the upper and lower teeth overlap as much as these do in the front, particularly when they're a female, you're very likely dealing with a TMJ pattern. And we were here. Please notice she's never had any orthodontics. She's not had teeth taken out, but she wants to be free of pain and sleep apnea. Her face is back, like many people. I actually believe she modeled in her earlier years. She's an attractive woman. Her forehead is sloped back a lot. We've done something completely countercultural here. We have opened up spaces for her between her bicuspid teeth. You can see on the upper arch there, she has implants placed, and they will soon be restored in the next picture. But her headaches are gone, and her snoring is completely gone. We don't have a sleep test to know whether her apnea is gone because she didn't want to spend the money on it. Nobody wants to when they feel great and they're sleeping well. So this is not the standard of care. Again, I would be told, having done this, I would push her teeth off the bone support. Now you see that crowns are placed on the implants, and so she has 4 extra bicuspid teeth, and her snoring is completely gone unless she wears her retainers, which we now have her wear during the evening rather than sleep with them. And I haven't seen her for a while, but she's had no headaches or migraines for 2.5 years. That's as of soon to be 4 years ago. I am certain that she'd be back if there was a problem because she's a good friend of mine. But you can see the broad smile versus the narrow smile. Who has more room for their tongue? Who's going to have better head posture? The one with more room for the tongue or less room for the tongue? If I went to a peer review because someone said I shouldn't have done this, that's a view of the peer review committee right there. They wouldn't be too happy with me. And yet the patient is incredibly happy. So let's get on what happens if people have teeth taken out. And it's not so good. We have a syndrome that I've named, and you know what a syndrome is. It's a medical signs and symptoms that are correlated with each other and often with a specific disease. I have identified a syndrome. We call it extraction, retraction, regret syndrome. Now, when I lecture about this, people will laugh about it. But if you're a sufferer, you're not laughing at all because you know I'm right. And I get people from all over the world that contact me and say, oh my gosh, I read about this and I am a sufferer. There's a constellation of aesthetic, functional, and emotional signs and symptoms caused by tongue space, airway reduction from orthodontic retraction, all of which are preventable. Let's go a little bit further. How bad can it really get? Here's a young man from New Jersey, and you're not going to believe this case. You can see here he's given me all of his pictures, a chronic mouth breather from kindergarten on. He has a relatively normal looking face when he's in kindergarten, but by the time he's in high school later on, his face is long and V-shaped because he's a chronic mouth breather. And he's had orthodontics done. And he had 4 bicuspid teeth taken out at age 14, finished at age 16. This is where he comes to me looking like this with what we call an anterior open bite. His back teeth are together, but his front teeth cannot touch. This is a horrible relationship. It's not what he was left with after his orthodontics, but that's what happened to him afterwards because of degenerative jaw joint disease and the condyles literally resorbing away in his glenoid fossa of his temporomandibular joint. And here he is at age 27, and you're not going to believe the pictures you're going to see of him in a moment. And he's got a severe pain pattern, worsened over a decade, and it's overcome his entire life for most of his 20s. And when he flew out from New Jersey, he didn't even sit down because he was in such pain. He couldn't sit. He walked around the new patient room. And he admits literally he's a suicide risk. And everyone who knows him in New Jersey that he's seeing various body workers, his dentist, and an oral surgeon there are all worried that he's going to kill himself. Notice how far back his face is from the ideal that we might have, and yet he is not an outlier in our society. Millions of people in industrialized society look like him, but look at the amount of forward head posture that he has and his forehead tilt. And imagine what's going on for the rest of his body, up and down the spine. This is a picture of him immediately after the surgery. The surgeon has brought his jaws forward to correct the retraction which was done for him. The fact that he'd been ignored his whole life, been a chronic mouth breather, and as James Nestor talks about in his book, his face fell back. So here he is, surgically advancing everything. Here he is 6 weeks post-surgery, and he's now age 28, and he has an artificial jaw joint, a jaw like you would get a knee or a hip to address this. Please notice that he doesn't have an open bite anymore. The surgeon I've worked with does magic to bring the jaws forward. And he said this to me, those are his exact words when he came into my office. I was going to commit suicide. He now, after surgery, he weighs 117 pounds. He would weigh a little over 120 before the surgery. And I've referred him for myofunctional therapy so he can learn to keep his tongue to the palate, et cetera, et cetera. Here he is at age 19, at 170 pounds and a bodybuilder. And again, he was weighing 117 pounds post-surgery. How can a guy who is a health nut like this degenerate that badly and be ready to commit suicide? Here he is 2 months later. He's gained 20 pounds because he's eating 6 eggs for breakfast. Can't quite imagine that, but he's putting the weight on. And more important than that, he's happy and he decides to become a dentist. He now has a new meaning in life, to treat others like himself and prevent this from happening for others. You can look at the position of it, how the pre and post surgery, just 6 weeks later. And later on, here he is post-treatment. And you can see these doesn't have the forward head posture that he had before. The curve in his spine is more normal. And his smile is broader, and he's able to get his lips together and be a nasal breather rather than the chronic mouth breather. Here he shows me that his own posture changed. He took this picture of himself with his cell phone. I put the lines in showing how much forward head posture has changed. It's back substantially from where it was. And this is what he talks about. My body and jaw were in shambles. Every day was basically equivalent of human torture. I didn't open my jaw, speak, or move my neck for 6 months before surgery. That's how bad he was. So to finish up, if you like to read some of the best books out there, Patrick McKeown's book, The Oxygen Advantage, has been out there for about 5 or 6 years. It's great. He has a new one just released, The Breathing Cure, right here. He's a good friend of mine. We've known each other now for more than 10 years. He's a great guy. And the bestseller over here from James Nestor, which was released last summer. It's on the number 6 on the New York Times bestseller list, and is being translated into 32 languages. So I hope this has been helpful to you and eye-opening, trying to correlate poor rest oral posture, poor breathing, and how it affects the entire body posture, and pretty much everything else. If you'd like to contact me, this is how you contact me.
We'll have a link below this recording for people as well.
Okay.
Wow. I feel I need to take a breath.
Okay. That's fine. Should I take my screen down? Or?
You kind of scared the crap out of me, to be honest. You kind of scared me. So, and we're not used to scaring people in our work. So I just feel like I need everybody just take a little, I'm calling a calming breath now, not a deep breath, but a calming breath. And I want to see if I can understand a number of more basic things to be sure I get the major takeaways you want to give me. Okay, so first I'd like to ask, so the major reasons that you think humans' jaws have been changing are related to diet?
Diet and what we breathe. And it goes back to...
so just diet and, did you say diet and how?
Breathing and our breathing issues and allergies that we get, which causes people to become mouth breathers. But malocclusion was basically unknown until the advent of agriculture about 10,000 years ago. The hunter-gatherers didn't have malocclusion at all. And more recently, there was a study done by Weston Price, and he has a book out called Nutrition and Physical Degeneration. This was in the 1940s. He was former president of the American Dental Association. He toured the world and noticed that in the space of one generation, faces would change. The parents didn't have malocclusions and their kids did. And he went to remote areas around the world in South America, Africa, remote valleys of Switzerland, all over, and islands in the South Pacific, everywhere. And the one thing that changed was the adoption of a Western diet with refined sugar and flour and pasteurized milk. And you can read this book and you can see that, first of all, tooth decay was almost non-existent in the parents, but the kids got tooth decay. And more than that, the faces changed and they fell down and back.
Okay, so we think first maybe it's diet.
Diet.
We think that there's some bad breathing habits that start to happen,
Huge.
and I would think that maybe also functionally we don't use ourselves in ways that require the same kind of level of postural integrity. I would think that would matter.
There's another issue that I didn't even mention. I really should. One of them, it has to do with tongue tie, or also known as ankylosing. In Brazil, 7 or 8 years ago, they made it a law that all newborns should be examined for tongue tie.
Mm-hmm.
And by October of that year, according to sources I've heard, 47% of all newborns had some degree of tongue tie. Now, that doesn't mean their tongue was just anchored to the floor of the mouth, where if you stick the tongue out, you go like this, and the tip stays behind. But there's a gradation scale of that. The point is, and the reason that the newborns need to have that evaluated is many of them can't even latch onto the nipple. They can't nurse. If it isn't released, then they have to go on formula. And it's not just the formula versus the breast milk. It's the process of nursing that helps the face grow. And we've known that for a long time. There's another book, which is really cool. It's called, and I love this one for those of you who like it, Shut Your Mouth and Save Your Life, written by George Catlin, who at age 34 left his law practice in Philadelphia in the 1830s and went to live amongst the Native American tribes in the West. And he was an artist, and later on when photography came in, he became a photographer. But he wrote that book called Shut Your Mouth and Save Your Life, was published in the 1860s. And he noticed how the Native Americans had better looking faces, had less infant mortality than the Caucasian kids on the East Coast that he was familiar with. He noticed that the Native American women, when they take the child off of the breast, they would make sure that they take their fingers and shut the child's lips together, make sure that the lips came together. And also he noted that the Native American kids slept out and they never had their mouths open, they slept with their lips together. He talked about even in the 1830s, children on the East Coast were commonly sleeping in rooms that were warmer and had their mouths hanging open. He then drew pictures of the faces and showed how the face changed from what he called mouth breathing. And it's a very compelling book. It's still available on Amazon for those who want it.
Okay, so those might be some reasons that are become cultural habits.
Yes.
About why we might have these issues. And then you're thinking that I think I understand that you're saying then the next big influence is this decision to remove teeth in order to help a child's teeth be crooked, not to be straight or pretty, or for the bite to align.
That, and so many people in our society since World War II, the World War II generation had my generation, the baby boomers, and many kids started to have braces. I did as a kid, and I had a tooth taken out, and no one ever considered it. Realize that this is the kind of thing, orthodontics is taught from one generation to another. And although they pay lip service to being a lot of science behind it, there is no science behind it at all, from my perspective. And I have quotes from orthodontic department heads essentially saying that. The German government 2 years ago this month, from what I understand, stopped paying for traditional orthodontics because they did a meta-analysis of the literature and found there was no long-term benefit. realize that there's a lot of things that went into the orthodontic profession. That a lot of ego things happened in the early 1900s, and there was certain people who started advocating for taking out teeth. If you really read these stories, you realize there is no science behind it at all, and it's really kind of crazy, but there isn't.
Well, I think, and this is of course just my opinion, but I think when we culturally get into an idea about what beauty is supposed to be, and we start trying to match everybody up, we get into a bit of trouble, and we kind of all fall into the trap together, not just
No,
the professionals, but
I agree 100%.
yeah. So if I were a parent and and I had a young child that I was concerned about, it seems like one of the first things you're saying is you would want to be concerned if your child breathes with their mouth open all the time, or if
Yeah,
the child is snoring all the time.
exactly.
That those are things that need to have a look at from the terms of an airway. And
Exactly.
okay. And then definitely those are things that need to be evaluated before you start letting someone remove any teeth, because that's going to potentially make it worse.
Exactly.
Okay.
Really, for the mother who has a newborn child and the parents, this is critical. The earlier this is recognized, the better. Breastfeeding for as long as is possible, that's very, very important. And then when you wean the child, you should wean. There's a great book out there called Baby-Led Weaning by Gil Rapley from London. She's now passed away. But you don't want to use baby food. You don't want to use food that has been chewed up and ground up in a processor and you just spoon it into the child. That's not okay. Although we did it for our kids and it's very common, you want to wean them to hard food that they have to, even with, they don't even have teeth in, you still wean them that way. Then other things you look at, the child, is the bed torn up like crazy? And as a child age 6, 7, and 8 still wetting the bed, so many of those kids are sleeping horribly. The bed should not be torn apart in the morning. The baby should sit in there and lay there and not mess around that much. It's very, very important. The real big issue is when you see that the child you say something to him and have him do something, it goes in one ear and out the other. He's very crazy. He's like a bumblebee. He's there, and everywhere. And those are the kids that get diagnosed with ADHD.
That's what my next question was going to be, as what are you seeing as the relationship to ADHD?
Okay, I won't even tell you what I see. I'll tell you what Steve Sheldon, who's head of Lurie Children's Hospital, pediatric sleep clinic in Chicago, says. Steve has got books written on sleep apnea. Very great guy. He says, I do not believe that there is such a thing as ADHD. And he says it again, I do not believe it exists. I believe it is always, and he uses that term, which is a very crazy term to use in medicine, isn't it? I believe it is always a sleep and breathing problem. When you then look at the facts and figures, and the number that I saw maybe 4 or 5 years ago, 15% of our kids are being diagnosed as ADHD. Now, those are the kids that the teacher wants to kill them. They're all over the place. They're disruptive in class, and that's the way they are. They haven't slept all night. It's paradoxical. When an adult is sleepy, they fall asleep, right? When a kid is sleepy, they go crazy. And then when they finally have no energy at all, they will finally fall asleep, but they go through all this craziness. For those who really want to understand this, there is a great video on YouTube called Finding Connor Deegan. Connor Deegan was a young boy in the suburban Chicago area who basically said the world would be better off without me. And he told his mother that. And he was disruptive in class, and he was about one performance away from being institutionalized. I've met Connor. He's a nice kid. I've met his mother. I have met parents who had their kids in class with Connor. Connor went to see Steve Sheldon, and one of my many residents in Chicago is a pediatric dentist. Kevin Boyd is his name, and diagnosed the problem of sleep problems. He had his tonsils and adenoids removed, and he had his upper jaw expanded. Connor Deegan is a totally normal kid now. Very nice kid, doing well in school. Think about what might have happened to him if he'd not been that way.
Let me also ask you about this rest oral posture again. So in many different types of traditions, they teach putting the tip of the tongue behind the teeth. They don't talk about the rest of the tongue.
Right.
And then there's also people who talk about a relaxed tongue that's just sort of like hanging out in the mouth with the back of the tongue touching the two
Yeah,
teeth. You said it should be firmly attached
to the palate.
to the
Right.
palate. Now that's some muscular effort. That's some extra muscular work that got asked of me in my class this week.
Yes. Yeah.
And you're also talking about not just the hard palate, but some of the soft palate as well, are you not?
It's just the back, it should be naturally up against the hard palate mainly, not so much back to the soft palate, I don't think, but firmly up to the hard palate. The point is to make sure that you're nasal breathing and you're not just hanging the mouth open. Otherwise, what happens is that the face is going to lengthen more. Uh, there, there are people who have very long faces, V-shaped faces, from here to here, are very long. Those are the ones who hang their mouths open all the time, and they'll end up over time, they'll get a long face.
Mhm.
Very classic example of that is Michael Phelps, the swimmer. You see, he was a mouth breather. There are pictures of him when he was really young. He's a mouth breather. And there's also a picture on the internet of his mother feeding him with a bottle. So, I mean, the point is that's how someone gets that long face. And in his case, it hasn't affected him that much. He's the best swimmer in the history of the world. But if his face were further forward, my bet is he'd hydroplane over the water. He wouldn't even touch the water. He was such a great swimmer.
So there are other causes of sleep apnea, but you see an awful lot of them related to.
And I don't want anyone to think that everyone who's had retraction is going to have this. That's not the case at all. Some people are okay. But the point here is we know that people look worse when they've been pulled back. Their faces are down and back, their faces are longer, their chin are more recessed. Even though their teeth are straight, they really don't like the way they look. That's where the whole aesthetic thing comes in. But more than that, some of them can adapt and they're okay, but so many can't. And it's so simple. I mean, there was a time when I took out teeth in more than 50% of my cases in the first few years of my practice, with zero change in the patient population. In the early 80s, I literally stopped taking out teeth. And I got better. I feel I got better looking faces in my practice. I used to practice in Vermont. I had people coming from all over the state to see me because I was known as the guy who wasn't taking out teeth and the faces were better looking. There was orthodontists everywhere, but they were coming to see me. My practice was great. I didn't want to live there anymore, and that's why I moved to California.
Now I know you're interested in I'm sorry, my myofascial approaches. I guess I'm wondering if you think there's any possibility that people who work with babies from an early age, like some of us specialize in that as Feldenkrais and I'm sure there are other professions. Do you think there's any chance that we would be able to, if we understood the issues, we would be able to help the child's facial structure develop more normally or not?
Absolutely.
Okay.
Totally, absolutely. I mean, I've been connected with some cranial osteopaths, and I have 4 grandkids, and I had all 4 of them evaluated by a cranial osteopath. I believe it's critical. I believe those things in the early postnatally, particularly. What's really crazy here, and you're going to really not like this at all, is that we have some evidence. Some people that I know are looking at what do they do with the prenatal, looking at babies in the womb?
Oh, ultrasounds.
Ultrasound. I'm having a moment here.
Yeah, I understand. Yeah.
Ultrasound we're showing in the womb that the kids their faces are already recessed. The point is there's a lot going on that we really don't fully understand yet. What we do know is the farther back the face is, the smaller the airway is, and all these crazy things are happening. But we don't entirely understand all the reasons that it's happening. As orthodontists, we were taught there's a large genetic component to it. But there's a guy who's Robert Corcini, retired anthropologist at Southern Illinois University, has written books on this. He would argue that there's little to no evidence that there's any genetic change that's causing this to happen. It's more environmental. That's where you get into the great discussion about what all is happening. And with all the environmental things that are out there. I mean, you could go on and on and on with this.
I have one last question for
Yeah.
you, or I think might be helpful for those of us who are in the work of helping people with their posture. So when I see head forward posture, I start working throughout the system to, help people begin to sense their head in space and their weight
Right,
on their feet and blah, blah, blah. I mean, really powerful things.
right.
And I'm thinking, in my mind, to be honest with you, I'm thinking that their airway might accommodate as their head comes back on to their spine. You sort of seem to be indicating it's not going to happen, Cynthia, if they have a retracted jaw.
If they've been retracted, and the space is really that small, it's not going to happen. I don't think. John Mew says that to have your tongue to the palate properly, you need a 40 to 42 millimeter intermolar width. Those people don't walk through my door. I usually they're 30, 32 millimeters at the most. Many of the bicuspid extraction patients are down to 26 millimeters. I mean, it's crazy. I have a gentleman, 60-year-old gentleman that started out at 26 millimeters, and he had horrible apnea, and he said, I'd awaken thinking I'm going to swallow my tongue. Just with our reopening protocol, we've gotten him without any surgery. We have him to a 38 millimeter intermolar width. He's better. He actually had to have surgery and all. But if you're dealing with a maxilla that's that small, unless someone does a pretty miraculous job to try to get their tongue up there and keep it up there with a lot of myofunctional therapy, they may just not have enough airway. I have a 36 millimeter intermolar width myself. I've gone from 29, 30 some years ago. I expanded my jaw, reopened the space. I tape my lips every night and have for a decade after I heard Patrick McCune speak. If I make it to February, which is just a few days from now, I will have 2 years with no cold because of taping. And I used to get a couple colds a year. But my point in saying this is I tape my lips. I know my mouth is shut, but my tongue is forward between my teeth as I do this, meaning I need more tongue space because that I can survive and I can sleep, but my tongue obviously needs more space.
So what I think the point that I appreciate that, and I think the point that I wanted to make is perhaps the awareness of us who are working with people on the importance of noticing that people are mouth breathers, noticing that people are complaining that they don't get enough sleep, and that maybe trying to noticing that their jaw is retracted, that
Right.
maybe there's other things besides just what we're doing that need to be in the mix for getting them a healthy airway.
What we really need in the healthcare arena here is to work as teams. You need to I'm fortunate that I've been able to do that. I have my team of people. I have a cranial osteopath. I have a myofunctional therapist, and in the severe cases, I have a surgeon who can bring it all forward. And that we all need to rely on each other. And I truly believe what you're doing, particularly on the young people, the little ones, is so important to get them on the right track. And if you do, it's great. If you don't, what happens with this, once they become, like the kid who gets the large tonsils, people make the case were the tonsils enlarged because they were a mouth breather, or did they become a mouth breather because the tonsils were enlarged? You're going to have people with PhDs argue that. But what we cannot argue with is once the tonsils are enlarged and they are a mouth breather, just removing the tonsils won't necessarily make them become a nasal breather because it becomes a habit. So you can
Right, absolutely.
it's
Yeah.
great to try to get a myofunctional therapist to have the child do some exercises. And boy, when you see a kid sitting in your chair, I have these where they're sitting there, they look so good and they're breathing through their nose. They just have a look of health about them versus when they were the ones hanging their mouth open when they first came in.
Dr. William Hang, I thank you so much for agreeing to be with us. I know it's an unusual audience for you, but thanks for coming, and thanks for your passion. Although you did scare me a bit, I'll try to calm myself down. And
Please realize that the orthodontists are doing what they've been taught, and they're well-meaning. You have to understand that. But we got to go beyond that and start asking the really hard questions. Okay.
yeah.
Thanks so much.
Thank you. Thank you. Everybody, be sure you tune in for the panel discussion because it's going to be lively. I believe it is. So come to the panel discussion. And again, thank you so much. We'll say goodbye until we
Thank
see you
you.
again.